topic I have been offered is to talk about planning, preoperative and intraoperative. How do you make sure you're safe and how do you deliver the best for the patient? And the guidelines that in Ireland, we've chosen is to just follow the NHS guidelines. And NHS England and British Orthopaedic Association have come up with very clear-cut guidelines. The most important thing now is to make sure you deliver essential trauma and orthopedic care, mainly trauma. All elective work is curtailed, except emergency or planned tumor cases are the only elective cases that are being done. Now, for the proper delivery of trauma care, the local hospitals have been asked to do their bit, their local solutions. The guidelines are given, but how you implement and how you run your service is up to you. And as Dr. Abhay was saying, the most important thing here is you have to work with resource restraints. You would have about half or 1/3 of the staff. Your supply chains into week or next week may not be guaranteed. Your theater access. We used to have 7 days a week operating for trauma. Now we share the theater with general surgeons. And the same thing with ICU and HTU. Access may not be available. So for the orthopedic cases, there are about 4 categories. Most of the trauma that comes to the injury units or the emergency department are seen by the orthopedic teams now. They don't go through the ED. And at the first contact, a senior decision is made as to how to manage this case. They don't go through the usual loops. And only, I would say, about 1/3 or 1/4 of the cases come to the fracture clinics. Most of the treatment is now non-operative. And Chanley's close treatment of fractures, this book has now doing a big comeback. And the Cambridge University Press has actually made this book free. You can download all the chapters as PDF from the Cambridge University Press website. Upper limb cases, as Dr. Abhay said, they become day cases, and only the hip fractures and open fractures are now becoming the inpatients. Only these patients are being admitted. The main thing about these cases is inpatients is to operate them quickly and discharge them from the hospital very quickly. Although we are trying to minimize the turnaround time, everything during this time takes long. For the patient to be sent from the theater, from the ward to theater, setting up the case in theater, operating, the whole thing takes at least 2 to 3 times more. Again, you won't have the same scrub staff, or it's completely different environment. And I don't know how many have you operated with a full PPE gear on. The FFP3 mask that we've been given really suffocates you. In about 20 to 30 minutes, there'll be a lot of moisture. You will be trying to breathe hard. Your lungs will be working against resistance. And imagine if you have that with a difficult operating scenario, you will get fatigued and tired quickly. So it's very important to know how you actually would be feeling and how fatigued or how tired you'd get once you wear a full PPE. The important thing is when you operate on corona positive patients, what are the precautions you need to take? Because the staff, especially the anesthetists, are in the firing line. It is when you intubate and you extubate. These are the real high risk times. And as per the guidelines adopted in Ireland, when intubating and extubating, it's only the anesthetic team that will remain in theater. Everybody goes out. You preferably use a laminar flow theater. It will not be a negative pressure theater because negative pressure theaters are rare. So in the laminar flow, you wait 10 minutes for the airflow to clear up. So after intubation, you wait minimum 10 minutes before you enter with your full PPE on. So 10 minutes is gone. When the patient is extubated, again, minimum 10 minutes after extubation for the air to clear up. So you would have lost minimum 20 minutes during intubation extubation. That's why most of the patients, if they can be done, either are regional blocks or spinal anesthesia. GA is a big no-no in the corona positive or suspected corona positive patients. Okay, so as I mentioned, the PPE, you have to have a buddy system. Two people have to help out each other, donning in, donning on, and doffing off. It's very important that you take out your PPE in a proper manner and disposed of carefully. If this is not done properly, you put yourself and your colleague at risk. So buddying system and donning and doffing is very important to look after ourselves. As I said, the 10 minutes is very important. And when you have a patient with a corona positive, all the staff members are locked. You cannot have people running around for implants and equipment. You have to have everything in the buffer zone. The circulating staff brings the equipment you need in and out. So it's very important that you template, you have the plan A, plan B, plan C, and everything equipped when you are operating on a corona positive patient. Now, this looks probably very basic. We haven't operated on a proven corona positive yet, but the most important thing is the FFP3 mask, and it's very difficult to breathe through the mask for more than 30 minutes to 1 hour. If you're operating on a 2-hour case, I'm sure you'll be wrecked by the time you finish. And this was my anesthetist yesterday in the theater. So buddying system, donning, doffing, intubation, extubation. The most important issue here is when operating, you have to minimize the aerosol producing procedures, which would be when you're sawing. The other thing is a lavage. No pulse lavage in the corona period. Pulse lavage is gone. When you're using a saw or a burr, you really have to be careful. And these are aerosols that we produced. Again, there is no science behind it. This is all very new, and we have to see how the aerosol producing procedures will affect the theater staff. And you have to minimize the traffic in and out of the theaters. All the upper limb cases should be done as day cases. It will minimize the hospital stay and the hospital environment. And the important thing is these patients, they, if possible, can be discharged home. Absorbable sutures, splints, the casts are gone. Either you go for a soft cast that can be removed at home in a few weeks, or a splint. So the full cast now, which would normally be removed in a classroom, are gone. This complete change of practice that's happened. And coming back to the treatment decisions, on most of the conservative treatments are being made by the senior clinician. We have now an app called Silo, which is similar to WhatsApp, but it has a GDPR clearance. So you can use patient's data for it. You can print it off a PDF and file in your chart. Now we're using Zoom or all other virtual platforms for follow-up. Even the physiotherapists are doing the follow-up physio assessments on the virtual platforms. So all unproductive attendances in the hospitals have been cut. We don't want patients to come to the hospital for follow-up. It can be done on the virtual platforms. And the minor OTs have now made a big comeback. I still remember the days where in Osmania we used to have a small minor operating room. under ring blocks and regional blocks. We used to do stuff and send the patients home. They have disappeared. I haven't seen them in UK and Ireland, but now we have a minor operating room in the emergency department. That's a big comeback. Life goes on in circles. So this was one of the case, because of the lockdown, the injuries have changed. Everybody's now taken up DIY. They're trying to do some work at home, fall from a ladder. You can see how bad this calcaneal fracture is. And imagine I had to decompress his foot at 1 o'clock in the night. I've never seen a compartment syndrome in a calcaneal fracture. So that was last Tuesday. And trampolines are back in the backyards, and you can see the Gartland 4 type of fractures there. Now, this was a hip fracture in a 94-year-old lady. And as soon as a chest x-ray was done, you can see there's a pleural effusion. And then the alarm bells ring. Is it a COVID positive patient, 94 years? No temperature, but she's got lymphocytopenia. So we treated her as a potential COVID positive patient. She was operated yesterday. So these are all difficult times, and I think we have raised the bar. Who would have thought that in 2020 we will go back to reading Chanley's book? Thank you.